Good morning, everyone, and thank you for having me. Truly, it's a good time to be in glaucoma. The future seems very bright. Can I have my slides? All right. So I'll be talking about counseling. Okay. I'll be talking about counseling in glaucoma. Everything we've said, beautiful, but I'm a very practical person. If we don't speak to our patients, if we don't convince our patients that this invisible disease is actually in their eyes, they will keep on hopping and they will keep on shopping. So for me, once a patient comes, I tell you, we're best friends for life. It's because whether you use medications, whether you're doing laser, whether you're doing surgery, you will have to follow up your patient for life. So let's talk about a little bit about counseling. These are all, sorry. Okay, so glaucoma is largely asymptomatic, like we know, especially in the early stages, and the patients may not even perceive the importance of treatment. So you need to be able to convince them that even though they look well and they think they see well, there's something that would cause blindness, and lifelong treatment is needed for these patients to sustain their vision. So motivation and adherence is extremely important in these patients. Now, other issues are the psychological impact. Once you tell a patient you have glaucoma, they've heard that there's a disease that causes blindness. So most of the patients even are depressed. Once they hear it, they are depressed. So you may even need help with the psychologist or other people to help you talk to this patient. It's a very complex treatment. We've heard about all the paradigm shifts in medical therapy, in surgical therapy. So it's something the patient has to grapple with for life. The treatments are very complex. So what are the goals? We want to be able to educate this patient about the nature of the disease and the consequences of not taking up treatment. To foster trust. Trust is very important, and the doctor-patient relationship is key in making sure that this patient achieves, a sustained vision. You need to encourage the patient to adhere, whether it is medical, laser, or surgical, and ultimately you want to improve the quality of life in this patient. You need to address the patient's concerns, and you have to consider the patient's present lifestyle while you are choosing treatment. So let's talk a little bit about understanding the perspectives of the patient. Sometimes the patient comes and I feel fine, doctor, why do I need treatment? That's one of the commonest things. So you have to explain that this is a silent disease because that's the commonest glaucoma in our environment, and that's the one that the patient may not present. So sometimes it's a chance finding. You need to explain that this is a silent disease and that it is irreversible, and that's why they need treatment. The patient will want to know, will I go blind? So you need to assure the patient or reassure the patient that with proper treatment, the vision loss can be prevented. Can I stop treatment? These are some of the questions patients ask. Once my pressure is okay now, because if you say my pressure is 40 something and the normal should have been less than maybe 20 or 21. Okay, now that it has reached 14, can I stop the treatment? You need to stress that this is a chronic disease and that there is need for a lifelong treatment. Eye drops are expensive. We've heard about lasers and all the talks. You need to think about, other things. If you have lasers, if you're lucky, I don't know how many centers in Nigeria actually have lasers, but if you do, you may want to consider options like lasers, especially if it is subsidized, so that the patient will save cost. But if you have to use medications, you have to consider generics and HMOs and other ways that the patient can access these medications. Surgery sounds dangerous. In fact, once you say surgery, the person like, I hear it a lot. I heard that there is no surgery for glaucoma. That's what patients say. You need to reassure them that there is surgery, but that the surgery is not geared at improving vision, but maintaining vision. So you need to be able to speak with your patients and get the patient's confidence before the patient takes up treatment and stays in the treatment pathway. So how do you counsel these patients? You have to consider the patient in front of you. So for me, I'm a firm believer in a patient-centered treatment approach. There is no one cap fits all. Every patient is different. Let's say you have a newly diagnosed patient. The patient obviously will need a detailed education about what the disease is all about and emotional support. You must be empathetic as a glaucoma doctor. You can't just sit there and start calling very big names without considering that the person in front of you is grappling with fear of imminent blindness, considering his pocket, his family, probably even has other systemic comorbidities that he's struggling with pain. So you need to counsel the patient. If it's an elderly patient, they may also need assistance with drugs. So you may need the caregiver to explain how they will use drugs. Like I said, if you have other ways that will not need the patient to be putting the medication, we've heard of the intracameral drugs. I'm sure one day it will finally reach us. You look for the easiest things for these patients that make it easy for them. Reminders and co. If it's a working professional and you go and put the patient on 3 times a day, I don't think anybody needs to tell you that probably the afternoon dose will never be used. So you need to consider the person's job, what the person is doing, and the ability to work within what the person's day looks like. So you have to think about the work-life impact and the schedules. In those that have advanced disease, you must focus on the best way to preserve whatever vision is there and the fastest way to also get it down. So all our MIGs and MIBs and all the very lovely, but I don't know about you. I seem to be in a place where the patients that come are with advanced disease, high pressures, and my mind goes to trabeculectomy. So if you do a good trabeculectomy, you would at least bring the pressures down and get the patient to see for a longer time. So like I said, you need to listen to the patient, understand the fears and perspectives. Use simple languages in this patient. Don't blow big medical grammar. You need to explain. Like, our other speaker told us, you tell them that the meshwork is like a sponge. I'll tell them it's like a sieve you use to wash and that the pores are closed. And so this treatment now is to try to open the pores or to, just use words patients can explain. Like saying that glaucoma is like how you have high blood pressure in the body. But this one now is high eye pressure. It's like BP of the eye. Things like that, the patient will understand what you're saying and live better educated. If you have access to, and we should all have printouts, OCT machines, we have phones, you can go onto your phone, take pictures, download pictures of fundus images and co. And then you show it to the patient. This is what the normal looks like. This is what yours looks like. There's always this chart in my office by Pfizer. Had understanding glaucoma also. So it has the picture. So I will point to that. This is what it is. This is what your own is. The patient is better able to understand what you're talking about. Now, it is a shared decision-making process. Remember that the patient has to be involved. If you just reel out instructions, it's not going to be followed. So the treatment must be centered around the patient. You need to reinforce and repeat. The education is not one time. Most times when they come that first time, you tell them. The second time, they may have completely forgotten. So at each time the patient comes, you need to keep reinforcing the education. You need to consider proper drop installation if you're going to use drops and compliance strategies. Like I tell my patients, those that have phones, they have apps to remind you about drug installations. You can put a picture over your bed. Have you put your drop today? I tell that a lot to my patient. Just create a picture and put there. And maybe that will remind you. Or tie it to something that you do daily that reminds you. So let's talk about a few barriers and how we can solve them. Forgetfulness. You can think of reminders or linking your drops to daily routines. Like our other speaker says, she puts it on her coffee table for her medications for BP. What are the side effects the patient has? You can switch medications, cancel, you can treat for OSD, you can go through other things. Like if you have lasers, I would also suggest that you should consider SLT as the first line, at least spare the person of having to put drops and dealing with the side effects. But if you don't have, consider the drops with the minimal side effects. Consider the patient also. You can give somebody that has asthma, timolol. So look at the patient, ask questions, and know what you should do. If the person is worried about the cost, we need to think about generics. Consider HMOs. Introduce them to such things to help Next slide. All right, so the person has poor health literacy. You may have written materials, and they should be in the patient's language, or at least in a language that is easy to understand. No need big grammar with papers that the patient will need somebody to interpret. So go down to the patient's level. The patient is afraid of surgery. You could use people that have had surgeries as advocates or get support groups. The caregivers need to be also trained, and they also need to understand the process and why you're doing what you're doing. Next slide. So one-on-one counseling is very important at diagnosis, before surgery, and during follow-ups. Encourage group sessions like glaucoma patient associations. They are very important when these patients are with other patients. It makes more sense than doctor to patient. So when they see other patients that are going through the same thing or have had procedures, these are better advocates. Consider written resources via pamphlets, apps, and co. And this should be a multidisciplinary approach. Next slide. So, like I said, you need to counsel at every follow-up. Use adherence tools if you want to. Questionnaires to help the patients. Strategies based on the patient's feedback, the caregiver's feedback. Do this at every time the patient comes back. Try to get to the patient, know what the patient is going through. Ask the patient for side effects or any fears the person has. So that helps the patient to stay in treatment. Next slide. I'm not going to talk much about the next slide. Just give an example of a tool, but this will be good if you're doing a research. Next slide. So what are the key takeaways? If you want a patient to adhere to treatment, you need to educate and motivate this patient. Remember, it's a lifelong disease. So if you want your patient to stay, to take up treatment, you must develop trust with the patient. The patient has to know that you are actually interested in him as an individual and not just as a patient. You need to make sure that there is a personalized care. So no one cap fits every patient. A patient coming to you and the patient is not able to continue with drops, you need to think of other things. Don't say it has to be eye drop first before surgery, before this, or the other way around. So for every patient, decide what is best. Discuss also with the patient. And with doing all of this, we're able to ultimately preserve vision in our patients. I think that's my last slide. Thank you very much for your time. And by God's grace, we'll win the war.
Thank you very much, Ma. Thank you so much. Professor Afyong Ibanga, please, can you help with the question and answer session?